Hello everybody. Today we're gonna discuss about the topic called heparin and anticoagulants. Myself Omkar. Subtopics: heparin, low molecular weight heparin, heparin antagonist, direct thrombin inhibitors, oral anticoagulants, direct factor XA inhibitor, oral direct thrombin inhibitor. What's heparin? Heparin is an anticoagulant, basically blood thinner that prevents the formation of blood clots. Heparin is used to treat and prevent blood clots in the veins, arteries or lungs. Heparin is also used before surgery to reduce the risk of the blood clots. Mechanism of action: heparin exerts parts of its anticoagulant activity through interaction with antithrombin. Antithrombin binds specifically to a pentasaccharide in heparin. Binding to heparin induces a conformational change in the antithrombin, which accelerates enzyme inhibition. Pharmacokinetics. Absorption: heparin is not absorbed from GIT, must be given intravenously or subcutaneously. Metabolism: the liver, adreticuloendothelial system are the sites of biotransformation. Elimination: the average half-life is 1.5 hours and is dose dependent, excreted in the urine. Dosage and administration: for the immediate effect we have to give it intravenously 20 to 1000 units per day. Subcutaneously, for effect after the 20 to 60 minutes, 8000 to 10,000 units we have to give for every 8 hours. Indications and usage: prophylaxis and treatment of venous thrombosis and its extension, pulmonary embolism, peripheral arterial embolism, arterial fibrillation with embolization. Treatment of acute chronic consumption of coagulopathies is that disseminated intravascular coagulation (DIC). Prevention of post-operative deep venous thrombosis, basically known as DVT. Also used to maintain catheter patency and as an anticoagulant in blood transfusion, dialysis, laboratory samples and extracorporeal circulation. Basically, heparin shows interactions with alteplase, antihistaminics, antithrombin, cephalosporins like cefazolin, ceftriaxone, penicillin, parenteral is that ampicillin and penicillin G. Contraindications in severe thrombocytopenia, patient in whom suitable blood coagulation test cannot be performed. Hypersensitivity to heparin or any other product ingredients. Do not administer products containing benzoyl alcohol as an preservative to neonates, infants, pregnant women or breastfeeding women. Patient with hypersensitivity to corn products and bisulfides may be contained in some heparin sodium in dextrose 5%. Adverse reactions: hematological adverse reactions. Hematologic side effects including hemorrhage at any site have been reported the most frequently. Cardiovascular side effects have included new or recurrent arterial and venous thrombosis in association with thrombocytopenia. Dermatologic side effects have included extensive skin necrosis, necrotic lesion at subcutaneous injection site, musculoskeletal osteoporosis. Endocrine: increased pre-thyroxine level, acute adrenal insufficiency. Low molecular weight heparins. Heparin has been fractioned into low molecular weight forms. Molecular weight is between 3000 to 7000 Dalton by different techniques. Low molecular weight heparins are defined as salts having an average molecular weight of less than 8000 Daltons. These are obtained by various methods of fractionation or depolymerization of polymeric heparin. Basically, various low molecular weight heparins have been marketed. For example, enoxaparin, ramipril, nadropril, daltepril, permethrin, and adrenapirin. Mechanism of action: selectively inhibit the factor XA with little effect on second factor. Act only by inducing conformational change in antithrombin. Hence, low molecular weight heparin have smaller effect on prothrombin time and whole blood clotting time than unfractioned heparin. Also, they have lesser antiplatelet action, less interference with hemostasis, lower incidence of hemorrhagic complications compared to UFH. Elimination primarily by renal excretion. Basically, this is a flowchart of mechanism of action of heparin. The upper pathway shows the unfractioned heparin action and the lower pathway shows the lower molecular weight heparin. Basically, main action of both the pathways is basically same. Both act on the factor XA, but additionally, unfractionated heparin is also act on the thrombin. Advantage of low molecular weight heparin: better subcutaneous bioavailability, 70 to 90% compared to UFH unfractionized heparin. Longer and more consistent mono-exponential half-life is 4 to 6 hours. Since the prothrombin time and clotting times are not prolonged, laboratory monitoring is not needed. Risk of osteoporosis after long-term use is much less. Indications: prophylaxis of deep vein thrombosis and pulmonary embolism in high-risk patients undergoing surgery. Treatment of established deep vein thrombosis, unstoppable angina and myocardial infarction. They have largely replaced continuous infusion of unfractionized heparin. To maintain patency of cannula and shunts in dialysis patient. Heparin antagonist. Heparin antagonist is a strongly basic compound which reacts with strongly acidic group of heparin, thereby abolishing anticoagulant activity. Protamine sulfate, mixture of simple low molecular weight polypeptide found in fish sperm, binds firmly to heparin and inactivates it. 1 mg of protamine neutralizes 100 units of heparin activity. After protamine injection, patient should be observed for recurrence of bleeding as protamine sulfate is also an anticoagulant. Protamine intravenously may cause fall in blood pressure, bradycardia, dyspnea. It partially neutralizes low molecular weight heparin. Direct thrombin inhibitors. Unlike heparin, these recently developed anticoagulants bind directly to thrombin and inactivate it, without the need to combine with and activate antithrombin, basically factor 3, third factor. Example of these direct thrombin inhibitors: lepirudin, bevalirudin, ergotropium. Oral anticoagulants act directly by interfering with the synthesis of vitamin K dependent clotting factors in liver. Apparently behave as competitive antagonist of vitamin K and lower the plasma level of functional clotting factors in a dose dependent manner. They inhibit the enzyme vitamin K epoxide reductase and interfere with regeneration of the active hydroquinone form of vitamin K, which acts as a cofactor for the enzyme gamma glutamyl carboxylase. Mechanism of action of oral anticoagulants. Basically, it is the what we have discussed lately. For the inhibition of the gamma glutamyl carboxylase, the oral anticoagulants act on the vitamin K epoxide reductase. That's why vitamin K cannot be transformed into the hydroquinone form of vitamin K, which is necessary for the transformation of various clotting factors like prothrombin. Direct factor XA inhibitors act rapidly without lag time, have short lasting action, and example is rivaroxaban. This is the example of it is direct basically act on the factor 10th. Oral direct thrombin inhibitor, dabigatran ethoxylate, reversibly block the catalytic site of thrombin and produces rapid action within 2 hours anticoagulant action. Oral bioavailability is low. No laboratory monitoring is required. The plasma half-life is 12 to 14 hours. Duration of action is 24 hours. Usage of anticoagulants. Basically, anticoagulants are used in the deep vein thrombosis, basically known as DVT, pulmonary embolism, myocardial infarction, unstable angina, rheumatic heart disease, arterial fibrillation, cardiovascular disease, vascular surgery, prosthetic heart valves, retinal vessel thrombosis, extracorporeal circulation, hemodialysis, defibrillation syndrome or disseminated intravascular coagulation. Basically, these are the MCQ for you guys. go through it. If you are listen the whole PPT carefully, you can solve this MCQ easily. So that's it for the day. Bye.